Welcome, everyone. My name is Ed Marx, and I'm joined today with my good friend, colleague, Cris Ross. And we're here to talk today about patient experience, something that everyone has a deep interest in and works on diligently in their organizations. Our webinar today is really unscripted, unplugged. It's really led by you. So we already have many questions that have come in, and we're going to address all those questions. But there's also opportunity, because we are live, to keep asking questions. Sometimes some questions, when we answer them, might beget other questions. So please enter them in the sidebar there, and we'll certainly try and get to all of them and just take it from there. So we have 3 or 4 introductory type of comments, and then we plan to get straight to the question. So Cris, again, welcome. So excited to have you as our guest and have this discussion. And why don't you introduce yourself a little bit for those who might not know you, and then tell us about this book. So we're working on this book called there's no title right now, but we just kind of label it Patient Experience Turned Upside Down. So tell us a little bit about yourself and a little bit about this book, and we'll get to the genesis of the book and go from there.
Thanks, Ed, and thanks for inviting me to this session. These webinars are great. So again, my name is Cris Ross. I'm the Chief Information Officer at Mayo Clinic. I've been there about 8 years, and I've worked in other healthcare organizations previous to that. And as Ed said, we're trying to focus on patient experience, and I think it's an issue that, of course, was part of our portfolio when we're both CIOs and Ed now is a consultant to many organizations. But it took on a particular deep and resonant meaning for both of us as we've had more significant health experiences. And Ed will tell his about his own experience and maybe some caring for family members. I'll just share a little bit about mine. In summer of 2018, I was diagnosed with a stage 3 colorectal cancer and went through a fairly extensive journey of chemotherapy, radiation therapy, and surgery. And that whole episode took me until May of 2019. There was times along the way when I was feeling well enough I could pop up and participate in work and so on. But I didn't get back to the job until about May of 2019. And I learned a lot in that journey. I saw things that worked and things that didn't work. We had just implemented a new version of Epic enterprise-wide, and we had done the rollout in our flagship campus in Rochester, Minnesota in May of 2018. So I was being treated using the same system that we had just rolled out 2 months previously. So I got to see all the warts and kind of early learnings and those kinds of things. And it gave me a sense of focus that I think was really useful and raised my passion for being an advocate for patients. I'll say a little bit, my journey didn't quite end there. I had really put cancer in the rearview mirror, taken the direction that I was in remission, seriously, did the routine kind of surveillance that one always does. But in February of this year, 2021, I was diagnosed with a recurrence of that colorectal cancer, pretty much in the same location as my original cancer, which was a disappointment to me and to my care team. But we put the band back together. I went through chemo and radiation again, slightly different formula of chemo, slightly different radiation therapy, and then surgery this summer. I'm just emerging from that treatment. As Ed knows, Ed was kind enough to come visit me in the hospital, I think on day 3 or 4 when I was really a mess. I learned a lot in my second journey through. In some ways, I wasn't seeing it raw as sort of new technology currently deployed, but how it was being used today. And learned again a whole lot more about what the patient experience is like. Last little tidbit, because of some complications and because of where the tumor was located, I had damage to some nerves in my leg. So I currently can't use my left leg. I've got a leg brace and crutches, and I use a wheelchair when I have to go long distances. But the prognosis is that I'm going to get recovery of that leg. But I got to tell you, I spent a month in the hospital, and over that sort of long haul, you learn a lot. And I moved from place to place within the hospital, from sort of medical treatment into physical medicine and rehab. And we're going to talk a lot more about what we think is sort of the structure of patient experience, and what does it mean to be a patient and enter a system, and what's your duty and what's the duty of those of you around you to try and improve that patient experience. So sorry, Ed, I think I went on for some length, but I wanted to, let folks know, for us, this is not an abstract issue. This is close to home.
Yeah, to your point, Cris, I think a lot of us, all of us, right, can relate at some level about patient experience, because with some way or another, we've all been patients, or family members have been patients. But like this was pretty significant. And I also had a couple significant events with heart attack, which took me across a couple different health systems. And then I also had cancer. And so I've been through it all too. And now I'm helping, as many of us do, helping parents through their journeys. And I think we both agreed that it's complex and it's hard, and no one's got it, perfected. No one's got it down. And we're fortunate to serve at some great organizations that are perhaps a little bit more focused on it than others. But the point is that not everyone has that opportunity to be at Mayo or Cleveland or some other great organization that many of our participants belong to. And so our thinking was really about, wow, what can we do to ensure that patients have a great experience despite their provider, right? We look at it a lot of times provider centric, like what do we do as providers? And certainly we're going to talk about those things. What did we do as providers to enhance the patient experience? But what can the patient do to ensure that they have the same experience no matter where they go? Because we all know that a patient could come to a great organization and have a great experience, and a same patient with different with same outcome though could have a bad patient experience. So it can be uneven.
Right.
So that's why we're sort of saying, hey, we're going to turn it upside down. We do have a few objectives that you saw when you registered, so we are going to try to hit those and are hitting on this. But now that you know sort of the backstory, Cris, the book, how did it begin? People want to know, when will it publish, who's publishing it, those sort of things. Maybe we'll take care of some of those things and then jump into questions.
Yeah. So Ed approached me about the idea of putting this together because we had spoken about our experiences in a couple of venues and had gotten, encouraging feedback that said, say more. So we're going to try and say more. So we are hoping to have the book out in the middle of 2022. We have along the way gotten lots of feedback from our publishers about what kind of book, should we write? And we've made a decision with their guidance to write a book that's really aimed at patients as opposed to health systems. And part of our logic is, surveys show that most healthcare organizations are investing in improvements in patient experience, and they're trying to support patient empowerment. And you think about the things that are now commonplace, like portals and apps that let you see your results and manage your appointments and all those kinds of things. That was a rare thing 5 or 10 years ago, and it's not anymore. So part of this is certainly informed by our experience as healthcare executives, but it's deeply personal. And I think part of our view was looking at kind of a model that we've constructed to maybe think about this. So, maybe I don't remember when the book came out, Ed. I think you remember when it was a popular book of if Disney ran your hospital. People really looked at that, and they should. But I think our experience says that even if you do all those things, a patient journey is not like a ride at Disneyland. It's going to be highly curated, and you know what your experience is going to be like front to back, and everyone has a really lovely experience, and there's lots of support structures in place that's curated. It's more like going on a vacation to some remote place in the world when you have a significant patient experience. And if you've traveled, you have that experience of that lousy hotel that looked good on the website, or a flight got canceled and oh my gosh, it threw all of your plans into a tizzy. From that experience that you can't necessarily depend on the support structures around you to make things perfect. That our view is that whether you have a good patient experience or not, and depending on which health system you're in or not, a lot of this begins with you. And what's your intention of what you as a patient want to experience as you go through a health journey? And our belief is that there's things that you can then touch and feel, which would be like your friends and family around you, the village that supports you on a significant health journey. And then beyond that, what's your care team, the people you interact with? How do you communicate with your physician and the rest of the care team so you get what you want? But for a lot of people, there's some other things that influence your healthcare experience that are not what you can see and touch. They are the system that supports your healthcare. What are the policies of the hospital you're at? We've run into those experiences, I'm sure you have too, where you don't see something coming, you run into a glass wall. Why is it I can't get what I want? Or why is it that I'm having such a bad experience? Well, it's because the system made a decision to have certain processes in place that ensured patient integrity or patient safety, but they're counter to what you want to do. And it's frustrating when you run into those barriers and you can't move them. And then beyond that, there's sort of a community beyond that that includes all the things that influence care. And that might be who's making medical devices, who's setting federal and state policy for healthcare, what medical devices are available, what kind of breakthroughs are coming along the way. And some of those things are quite distanced and so on. So we wanted to write a book that was very personal around how can you take charge of the things that you can take charge of? And then for the things that you can't take charge of, how do we draw back the curtain a little bit and provide some sort of, guidebook or travel advice? We want to be the Rick Steves of patient experience. What's really going on behind the scenes that it's going to influence you. Again, Ed, sorry to go on and on, but I think that characterizes what we're trying to do together.
Yeah, that's really great. And it's being published by Mayo Clinic Publishing and Simon & Schuster. And we're really excited, especially that all the profits are going to cure cancer. So obviously that's part of Cris and my story, and many of you have family members that are impacted by cancer. So all the proceeds from Mayo Clinic Press and from Cris and myself, 100% going to cure cancer. So we're really excited about that too. So we're really passionate. We're not doing this for personal gain, but really because we feel like we got these insights, Cris, that you spoke about, given the sort of trauma that we've gone through, and have this new way of thinking about it, turning it upside down and really empowering the individual patient as the health systems, sort of catch up on the things that they're trying to do. So Cris, you already hit the model, and the model will be in depth in the book just because of the sake of time. We're not going to go much deeper in it, but Cris actually just took you through sort of that model, starting with you, the patient, and what you can do, and then building out your village and your care team and understanding the system. The last thing, then I promise we'll get to questions, because I thought this was really interesting, Cris, when we did some research. So the book, we developed the content for the book through not just our own experience, which we know is limited, and we know that our particular demographic is very specific, and we understand we don't know all the answers. We absolutely do not. So we did a lot of focus groups. So we did focus groups with leaders from small hospitals, leaders from big hospitals, and then we did focus groups with patients. So we had multiple focus groups with patients who are not part of healthcare systems. And then we did a focus group with populations that are not getting the attention they deserve from patient experience, because some of it's new and people are afraid of it and stuff. So we did a specific focus group for specific populations, and we probably have a specific chapter on LGBTQT, because without going in a lot of detail again because of time, if you really get into that, you'll realize that there are an underserved population. And so we also going to address sort of health and social equity as well. So covering a lot in that book, but again, that's sort of the model that you'll see there and how it was developed. And one key attribute, that's where I was headed. So we did a lot of research, did focus groups, but Cris, maybe share the one key attribute. It was kind of surprising to us, something we're going to focus on a little bit in the book, especially in that first circle of the patient. But can you speak a little bit about that key attribute that helps with the experience?
Yeah, we found both from our own experience, from the focus groups and academic research, that if there was a thread through all of it, was this idea of resilience and what it is that we can do to build resilience. Um, I have to say that through various parts of my journey, when things were going well, when the odds were against me, but things went well, I would have doctors or nurses, comment to me and say, well, you're a pretty resilient guy. Congratulations on doing X, Y, and Z. But it turns out resilience is something that can be taught. And it's something that people can tap into when they have a difficult moment. But I think we want to explore other things like how do you create resilience in the village that supports you? Caregivers can get tired. How do you make sure you don't wear out the folks who are supporting you? And I think we want to talk about a little bit about resilience in care teams and even in systems. How can they adapt? How can they adjust to difficult and emerging circumstances?
Yeah, so again, this book is being addressed to the marketplace, consumer market. As Cris mentioned, not specific to healthcare executives and people who serve in healthcare like ourselves, although we think it'll be of great benefit. But it was a really interesting twist, and I think it really important because we can all think about our relatives' experience or friends' experience. If we have tough times in our own experiences and we understand health systems and hospitals and how they work, imagine what it's like for 90%, 95% of the population. So this book is really aimed at helping them ensure they have a great patient experience no matter where they are, small hospital, large hospital, academic, non-academic. You can have a great experience. Okay, so we're going to jump into questions. If you have any more questions, please drop those in. Now, not all of these questions are super specific to the book, but you asked them and we want to be responsive and based on what we've learned to date on the book, happy to take a stab at this. So John asks, there are tons of niche solutions focused on patient experience and engagement. How do you pick one for your enterprise? And more importantly, make sure it's connected to all the data. So how do you go about this? So if we think about it again within the context of the book, Cris, how would we answer that question?
Well, it's a really great question, and without necessarily biasing against sort of a singular solution for the whole enterprise as opposed to kind of a niche tool or a focus tool. At least my experience is that the patient experience is based on that focused group that you're participating in right now, but also transitions from group to group. So right now I'm engaged aggressively in physical therapy, for example, to regain focus in my leg. And I'm really glad that there's a direct, focused set of tools that they can use to measure my progress and document things and help me keep track from visit to visit on how I'm doing and it creates my care plan. But, connecting that someplace else is going to be, a challenge to a large degree. It's always tough as a CIO to be judging between best of breed solutions and enterprise solutions. And usually it's the case that a best of breed solution is going to have some edge over a generic solution provided by an enterprise solution. Not always, but sometimes. And it's seductive to go after that last bit of 5 or 10% of functionality. I don't know, we could probably, do a poll on this, Ed, and we could talk about our various experiences, but at least for me, whether it's a single enterprise solution or something bolted into an enterprise solution, if you don't have integrity across transition points, I think it usually shows up. And I think that usually leads to frustration for patients and for the caregivers who take care of them.
Yeah, I don't want to be too prescriptive either because I definitely have a bias, but I would just think about it from consumer point of view. What do consumers have in other industries? Do they have to use multiple apps, or do they have with their airline or hotel system, do they have a singular app? Just think about what's working in other industries and how that might apply to healthcare. I can tell you we're helping my dad right now. So I've got great brothers and sisters helping my dad through horrific situation. He's doing really well though. But if we weren't there, the outcome would not be so good. But that's just the thing. We are doing all the care coordination because everyone's got their own systems. And if we weren't there tying it all together, a lot of phone calls, a lot of old-fashioned technology happening to make sure that he gets the care that he needs. And if we weren't there to help him, it just wouldn't happen. So you have to make up your own mind, but I always think look at best practices from other industries. That's usually a pretty good indicator. All right, Cris with a K says, how do you effectively gather C-suite support for patient experience items that do not have a direct or clear ties to revenue growth, right? Because we're dealing with finite resources, Cris, and how do you get the money to invest in patient experience if it doesn't lead to a financial outcome?
Yeah, well, I'll take first shot at it, Ed, and you can clean up my answer. I think the question is a really good one. I would take slight issue with the idea that C-suite folks are not interested in it. At least the organizations that I'm familiar with are really focused, especially in highly competitive markets, on how do they attract patients who aren't part of their system, and then patients who are in their system, how do they retain them, and how do they keep those patients from going elsewhere for part or all of their care. So I think that there is generally an understanding that customer intimacy and the ability to know who a customer is, a customer patient, I think is becoming more and more important to healthcare systems. I think it's the issue, they don't know how to do it. I think all of us are kind of struggling with, what do I do? And I think, it would vary from system to system, but at least I would say, in my experience looking at Mayo, as we try to advance things that will improve customer experience, we keep encountering these legacy processes that are in place that are really good and serve a really good purpose because they kept a patient safe, or they made the process more efficient for how a patient moves through a system, or it was something that really made the physicians happy and helped them do their work. And then you have to question those anew. Is it time to kind of tear down some of the old scaffold for a better purpose? So I think it's more encountering of old legacy processes more than it is kind of lack of interest or resistance.
Yeah, in the book, we're going to argue that we have a moral and ethical responsibility to make sure that we focus on patient experience, regardless of, if you could tie it directly to revenue growth. I would just say, sometimes I'll say things to make a point, and on this one is one of them where sort of controversial things, but I call it survival of the digitalist. It's like, if you do not do this, you are done. Okay, so in the past, you could be a happy little hospital, health system, and not focus on this because you can't show an ROI, and the CFO is saying, no, 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 no. But now that there's the new companies that have come in, the digital first companies, there's no more physical borders. Your city's not protected anymore. You can have other health systems come into your city now because it's all virtualized. You've got Walmart, you've got all this retail coming in, and guess what? They are all about the patient experience, and Amazon, and they will disrupt you, and they will take your patients. You're already seeing it with Amwell and Teladoc, the same companies that you're investing in some cases investing in. They're competing with you, and so if you don't do this, someone else will. I'll say one thing and we'll move on. I know I'm going to get in trouble, but I always say, if you're not, well, I'm not going to say it. I think we made the point. It'll take us off base. I don't want to do that. Let's just keep moving. But it's critical, and hopefully those answers that you heard from Cris and I would give you some other ideas. Alex says, when these shift of health systems, these organizational mindsets, going to consumer-facing digital tools are meant to enhance the experience of the consumer first, not be an operational tool for staff. So an example of online check-in, many times we see clunky UIs or unnecessary amount of information trying to be collected. Right. So they're saying what the question is, and how do you account for this, is that if we made it very consumer-driven, it would not necessarily serve the needs of operations. And so yeah, we see that today in check-in, right? It's not easy check-in. So I'm like, oh, finally they turned on check-in. It's automated. It knows I'm here, all that kind of stuff. But I'm still having to fill out a ton of information, not sure why, and because it has all these operational needs. So it's meant to make a better experience, Cris, but in the end, we're adding all this extra baggage to it. So how do you moderate for that?
Yeah, that's a great question. So I would give an example from our health system. We're trying to do more and more online scheduling, and it turns out online scheduling works pretty well if it's an episodic kind of thing. I want to get a mammogram done, or I want to schedule an appointment with my primary care physician. But for people on more complex healthcare journeys, it's more difficult. How do you schedule, broader kinds of things? I had a fantastic experience being treated by my own system, but I can think of examples of things like I couldn't schedule my chemotherapy sessions in advance. And the reason why is we had some rules in place around you needed to have a review from your oncologist before you could schedule the exam. Well, I get that, but I also know I was going to do 8 chemotherapy sessions come hell or high water, and scheduling them out, all 8 sessions, shouldn't have been so hard, but it was. And I think it's going to be the case that as an empowered patient, if we're going to serve me, that's going to cause some challenges for these back-end systems, as the question implies. And they're going to have to think about how do they re-engineer their processes to support this idea of, starting with the customer first. This is going to be really hard work. I don't know how this is going to compare to meaningful use and the implementation of EHRs that we've gone through over the last, decade, 2009 until now, but I think it's right up there, Ed. And you've spent a lot of time looking at health systems that have implemented digital first kinds of approaches, but it's necessary, it's inevitable, it's the morally right thing to do because it's the way to deal with things like health inequities and underserved populations. These digital tools and consumer first approaches are going to make things better for the patient, and they have to be done. But they're going to be really tough, and they're going to disrupt back-end systems a lot.
Yeah. John made a comment, sort of question. John, I agree with your comment around, in the study that you see improving patient engagement experience saves money. It also helps make money, right, with star ratings and things like that for reimbursement. But your angst sort of is, and I share that, is, don't healthcare execs understand the cost benefit analysis? And there's so many competing things and shrinking margins. That would be the reasons that they would say, well, we can't do it. But again, I think it's a little bit short-sighted, and that's why we hope our book is, there's plenty written about encouraging executives, encouraging people in healthcare to do patient experience. We've actually been doing patient experience for, I would argue, 20, 25 years. We called it something different 25 years ago, but we were sort of doing patient experience. We've been working at this for a long time, and we haven't gotten to where it needs to be. That's why we're excited about this book, because with the book, we're going with the consumers, with the patients, and helping them, and then hopefully meeting the health systems halfway, and really rethinking, reimagining how the patient experience can be, because it's not working top down. So I get it. We're down to like 2 or 3 minutes. I know we could go for a long time. So Praveen had a question on key trends in the changing consumer behavior. What are expectations from health systems of healthcare IT service vendors to improve patient experience? So either one, Cris, and we only have like 2 minutes. Key trends in changing consumer behavior, or what are the expectations of people like us from their IT service vendors?
Yeah, lightning round. So I would say one of the things that's going to affect consumer behavior is high deductible plans. People are increasingly thinking about cost of care first before anything else. And so they're looking to see, where am I going to get care that's high enough quality at an acceptable price. Also, smaller companies are dropping their insurance coverage, and more people are going to the individual insurance market. That's going to have other effects too. So it's become a consumer experience, sort of like buying a car or refinancing your mortgage.
Yeah. The last one, just look at the timer. I don't know if we can handle it in 30 seconds because it's a big one, from Kalia, is how do digital tools help the underserved populations, and especially those who don't have access to broadband? I'll say this, in our studies, we found that even in big cities, we did this in the focus groups, Cris, didn't it blow you away that someone said in their hospital, in their region, 40% do not have broadband? I know in big cities like Cleveland, it's 25%. So we have these great digital tools, let's do all this video, but I don't have broadband. On the other hand, what I've heard from Ram Raju from Northwell is that even nascent capabilities, on a regular phone, even a telephone, has really helped in some ways, because transportation was such a big issue, especially during COVID, and now at least they could get some level of virtual care in those underserved populations. So it's something that needs to be addressed, and we are going to tackle it in the book, again from a patient consumer point of view. But it's a tough nut to crack because it's a real issue. So, Cris, in 20 seconds, we're at the end of time. Is there something we missed, something you want to say to our audience today around patient experience?
I think only that we all welcome feedback as we're on this journey to try to document with integrity what these experiences are like. Ed's right, our experience is very atypical in some ways, but we're trying to broaden our aperture. So if there are folks who want to provide us with some feedback, we're still writing.
Yeah, I love that. We're definitely open. So yeah, we are still writing. We don't have a corner on the market. We get it. So please, if you're passionate on this topic and you want to provide input, reach out to one of us and we'll definitely get connected. Thanks, Cris, for being our guest. I'm glad you're healing. We continue to pray and hope for even quicker, that leg getting better even more quickly. And thank you for being our guest.
Thanks, Ed. It is always a pleasure.
All right, thanks everyone. We'll see you at the next webinar.